Ms. Chandra has distinguished herself with illustrious positions in the Ministries of Defense, Power, and Health. She has worked in different parts of the country with various state governments. She has also served as the Secretary to the Union Minister of Health and Family Welfare and as the Chairman of the Public Grievances Commission. Currently, Ms. Chandra serves as an independent policy analyst, op-ed writer, and a TV panelist. Her keen insight on issues related to governance, health, population, and gender, among many others, continue to be published in leading national media. Ma'am, it is an honor for us to be interacting with policy analysts such as yourself, who consistently push us to question and critique policies that are meant to enhance public welfare. Without any further ado, I'd like to invite ma'am to share her insights.
Good afternoon, everybody. Very nice of you to have invited me to give you a talk this afternoon. And I always value being able to say something to young people because they are the people who have questions, they have curiosity, and they have not made up their minds. So that is at least a big asset. I will be talking on the health sector in general. I'll come to the budget somewhat towards the end, but I would be certainly speaking about the totality of the health sector, because unless you know that, it's not possible to know what fits in where. A lot of it may be known to you, but to put it on a platform, it is necessary to put it that way. Let me put it this way. The health sector in any country, but certainly in India, always falls into two sectors, subsectors. One is the public health area and one is the medical area. When I first took over as Delhi administration, it was at that time, there was no elected government. I remember I used to be called Secretary Medical and Public Health. And although I was very new, I used to wonder why public health medical should do, because medical really encompasses everything. But that is not true. So to discuss these two baskets, one must understand that public health deals with millions. It deals with citizens on a scale. And it is very, very concerned about things like the probability of infectious diseases and how to be prepared to deal with them, how to be able to look at the preventive health side on all the issues which the population is might be suffering from. And the population really means knowing the demographics of that population. The demographics means how many people are young, how many are elderly, how many are young, what is their status within the totality of the country, the state, the district, and the sub-district. So from there, the public health people who are in charge of malaria, leprosy, TB, blindness, HIV/AIDS, they are able to monitor whether the ongoing national programs are reaching the needy people. That is also very, very important. Public health engineering used to be a part of the health ministry, but in many states, it continues to be running parallel with the health ministry, because that's very important for the quality of drinking water, because diarrhea and cholera and those diseases do happen to occur, and they can have a very, you can have very high morbidity and mortality, although it never makes the headlines, because somehow our media, and that goes without saying for every country, is very concerned about people who are visible and vocal, which really means the metros and the tier 1 cities, and going down to the villages and reporting something is very rare. But that is where the bulk of the population, 67%, as you all know, lives there. And that is the responsibility of a district administration, a district health system, to percolate down to the village level on not these diseases, but also to be on the lookout for something that may be happening. That's called disease surveillance. That's a very important part of public health. And the National Centers for Disease Control is the institution which is supposed to be on top of all the data, all the things that are happening across the country, and to be able to flag possibilities of an outbreak, an epidemic, and to be able to report it to the national government, and the national government is also expected to report it to the World Health Organization. So on paper, there is a very clear understanding of who is responsible for what, and the public health side looks after the preventive health as well as these large scale communicable diseases. And now recently, I'll come to that later, but now the non-communicable diseases have in a way overtaken the communicable diseases, which is all the things which are considered to be lifestyle related diseases, but they have become now chronic in the population and are hugely expensive to treat. Diabetes, hypertension, pulmonary obstruction, COPD it is called, CVD, which is cardiovascular diseases, that has completely overtaken in our country and is something that really we cannot ignore. That is a part of public health. So they really have a huge canvas. And if ever you talk to anybody, say in WHO or the World Bank, they will always say that saving a few lives in the best high-tech hospital is nothing compared to saving lives of millions, which is what public health does. But to be honest, public health does not get primacy, not just this government, any government. It has been my experience that it is unseen. Unless there is a problem, nobody is going to think of things like prevention. And if you talk about that, they're considered very low key. They don't seem to get eyeballs. They don't get any visibility from the media, with the result that the people who are not really, very who are able to project themselves, really these people might be doing a yeoman's service, but they are really in the background. So you come to the people who make a noise and get heard. That is the medical side. Within the medical side, it's not just hospitals. In the entire medical side, you have the whole hospitals business, you have the diagnostics business, you have the regulation of hospital business, and it all goes down to what is the latest equipment, what is the latest technology, what is the latest know-how, and how can you treat upcoming diseases and ongoing diseases and get people back on their feet and be able to ward off the worst possibility, which is of death. But even then, to get them back on their feet. What is not known, however, is that the medical sector comprises of central government hospitals, state government hospitals, which are very large. And like AIIMS, like Safdarjung Hospital, these are the kind of, you might say, very large scale hospitals. Even all states have state hospitals, which are usually anything from 1,500 beds onwards. They're very large. But they also have, in addition, large numbers of these district hospitals. Each district hospital, say there would be about 700, 720 district hospitals. They would all be having at least 100, if not 300. Usually it's 300 beds. So a lot of the public sector beds in the hospital sector are in government hospitals, in the state capitals, in the metros, and in the districts. Below that are the subdivisional hospitals, which may be having maybe 50 beds or something, but there the specialists are very, very low in number. So they're not really, people would prefer to go to a large hospital where they're assured that the problems of not having specialists would not arise. Now, when you look at the medical sector, what comes out is that it's not known very widely, but that's 62% of the beds in the privates, as it is 62% is what the private sector has in terms of beds, right? The rest is in the public sector. The 62% that is in the private sector is broken up into the chains, your Apollos, your Fortis, your Narayan Hridalia, your so many Kims, and a whole lot of chains, you all know about them. Those chains account for only 4 to 5% of these beds I'm talking about. The beds are like about 19 lakh in the country, the hospital beds. Of the 19 lakh, 11 lakhs are in the private sector. Of the 11 lakhs, only 4 to 5% belong to the hospital chains. The hospital chains are doing a great job. Why? Because they're able to give you very high-tech service at a cost which is really a fraction of what you would pay in any other, you might say, developed country. You would not be able to afford the kind of procedures that the private hospitals are doing in India. But remember that those private hospitals, the chains, usually are supported by foreign direct investment. And foreign direct investment came many years ago. It was Dr. Pratap Reddy. He was then in, he is the chairman of Apollo, or he maybe is chairman emeritus now. He started this and was able to get the government to open up this sector to foreign direct investment. When the sector was opened up, the health ministry wasn't in the picture. I was very much in the health ministry. Then we had not even heard about something called FDI. It was all managed in the finance ministry. And as time went on, the government policy was, if we don't have the money and we don't have the wherewithal, let the foreign money come in, let them set up hospitals, let it run like a business. So they ran it exactly like a business, which is, it is an industry. It is called the hospital industry. That is your 4 to 5% that I keep going back to. In the totality of India, it does not percolate to even the tier 2, tier 3 cities. It has no presence whatsoever in the rural areas, and their entire interest is to be able to work for the paying public. The paying public is important to them because it's not a bad word. It is a commercial enterprise in which foreign direct investment has come and Indian money has also come. So it is run exactly the way you would run, say, a power company, or you would run a telecom company. It is exactly the same. SEBI has the same role to play. The Ministry of Corporate Affairs has the same role to play. And ultimately, the oversight is more on the financial business and the way the financial business is being managed. And always there is a threat that you don't do anything properly. It is the financial side that you will get caught on. We don't have, unfortunately, a regulator for the private health sector. We don't have a regulator for the chains or for anybody else. There are many nursing home acts in every state has a nursing home act. Delhi's Nursing Home Act goes back to something like 1950 or something. Very rudimentary requirements. They don't have any staff, hardly 3 or 4 people. And the question of being able to regulate these, hospitals is simply out of question, with the result that hospitals are very much their own, it's only by word of mouth. Suppose something goes wrong, a fire breaks out, some death takes place or something which hits the media, they're worried about that. But other than that, profit is definitely very important because it is a business and you can't get away from that. What this medical sector, coming back to my story about the 4 to 5%, this I'm talking about the chains, the big hospital chains, which are running as an industry. But you also have the 95% which are left. And those 95% beds in the private sector are usually single hospitals. You know of many single hospitals, maybe 1 or 2, but nothing more. And you have below them a whole lot of nursing homes. They may be having 30 beds, 20 beds, 10 beds, 5 beds. And they are the people to whom a normal person living in a small township would go as the first port of call. When they go to this first port of call, they get treated, and often it is that doctor in the nursing home who says, I don't think I can deal with it. Nobody in this town can deal with it. You better go to either the district hospital for an operation, or if you can pay, you should either go to Apollo or go to Fortis or something like that. That is how those patients from outside the metros and outside major cities land up in those hospitals. That is how they get their clientele, maybe from outside, not only people living in that town, but the fact is that they're catering to a paying public. So when you find that this 95% is able to do things comparatively cheaply, I mean, your bills are not going to come in lakhs. You won't suddenly be caught and told that you produce 5 lakhs or you can't even take the dead body out of the hospital. That's not going to happen. But the snag with all that is that to keep costs low and to keep them affordable for the clientele that goes to them in the first place, which is the small town people, they would like to keep people who are paid the minimum. They don't want to spend on very qualified people. In fact, they're willing to keep even unqualified people and to train them on the job. Many of them do train these very people literally off the road, and they become so proficient that they become what is called RMP, which is Rural Medical Practitioner. It doesn't mean Registered Medical Practitioner. I have written a big report on this, and you can look it up. Unqualified medical practitioners, the social, legal, and medical dimension of their practice. It's on the internet. I did it for the Shivnada University. They gave me a senior visiting fellowship and said you can use the time to do this, and I did it. That gives you the nexus between the private practitioners and the rural medical practitioners. Informal, they don't have a degree. Most of them don't even have even a diploma. They are just, people who have learned on the job, sitting with the doctor, and having learned, then they go and open a shop and they're giving IV fluids and they're giving antibiotics and all that. I'm telling you this because that is a kind of a linkage which is going on. It's a revolving door, and whether it is a good thing or a bad thing, it's difficult to sit here and judge. After all, it's a large country. In rural areas, where do people go? The primary health center may not have a doctor, it may not have a pharmacist, it may not have drugs. A man has to spend a lot of money to reach that place. Remember, the distances can be as much. If you look up the spatial mapping of primary health centers and of the sub-centers, now they are called health and wellness centers. They are very, very distantly located from most villages. You take up just any one place. I had done a study for this, and it was on a website. I was heading the Janasankhya Sthirata Kosh, and we had put it all with the help of Survey of India and GIS mapping. It could be, you could go down to every single village and be able to see its distance from the nearest primary health center. And in most of the country, if you had bars, suppose you said between 0 to 5 kilometers is a yellow bar, and you say between 5 to 10 kilometers is a brown bar, and beyond 10 to 15 or more kilometers is a purple bar. The purple bars were so long and interminable. So in a way, you have to look at it from a patient's point of view. He or his wife gets sick or a child gets sick. They can't afford to go anywhere. They can't go and take that child to a district hospital straight away. They go first to the man on the spot, which is the quack. The quack and these quacks are generally very well behaved. They know the community. They are not fleecing anybody. In fact, they do it at literally 5 rupees, 10 rupees, 15 rupees. They give some dawa. Usually it works because we are a young population. But if it doesn't, they negotiate and take on their own scooter at times this patient onto the doctor, the MBBS doctor or the specialist who may be in the town. They negotiate and get him treated. Now there, if something goes wrong, then of course they'll have to go either to a district hospital or to the Bada Aspatal, which is in the up in the bigger cities. Now, this is important because one must realize that when you talk about hospitals, who are we talking about? If 62% is in the private sector, of the 62%, 95% is in this sector, which is this nursing home and hospital, this single hospital business. Will you ever be able to regulate these people? If you try and regulate them, the Indian Medical Association will not allow you to. And that brings me to an important point that in 2010, the government passed a Model Clinical Establishments Act. It's passed in Parliament, mind you, in 2010, in which they said that every single clinic, nursing home, hospital has to be registered. It must declare clearly, transparently, how many employees they have, what are the diseases they're treating. Is it just a maternity hospital? Is it doing hernias? Is it doing hysterectomies? Is it doing high-end surgery or just general surgery? They must declare it. But IMA did not allow this to happen because the vested interest in this is the minute you declare, you cannot say that you're keeping an unqualified doctor and unqualified. No, doctors are not unqualified, that's wrong. But the nurses are unqualified, the paramedics are unqualified. So they would have to declare that. The minute they do that, they need to recruit somebody to replace them. If they replace them, those people are going to charge 5 times what they're paying. The cost of running that nursing home will become completely unviable. So it's easier to say, just ignore it, let it go on. But actually, if you look at it, if you want standards and you want uniformity, unless you know who is doing what where, you are really just, talking of hospitals, medical sector, but not knowing who you're talking about and what are the standards, the minimum standards that you think should be adhered to. And are we really putting all our eggs in the basket of the big hospitals and thinking that that constitutes medical practice and medical health? Or are we looking at the totality? So I've tried to tell you this so that you know that there is this entire public health sector, which I told you about, which is your major hospitals, the district hospitals, the taluka hospitals, and then down to the, you might say, small wellness centers and things, which are OPDs. They don't admit anybody. But this structure is there in every state, going down to every district. I just want to digress for a minute and say that that structure was absolutely a lifesaver for India. When COVID came, and when you had all these, you might say, it was as early as March 2020. You remember the lockdown came, I think, on the 25th of March. I must have spoken to the district magistrate of Bilaspur on the 27th. And I said, there is a BBC article which is saying that Rajasthan is the new Italy because you've had 8 deaths already. And so he said, yes, we have had 8 deaths. People had gone abroad. They came to Udaipur and they had a party together. Now those people came to this hospital in my district, private hospital, and both the doctor as well as the patients were all infected, his friends, and some of them did die. So I said, what are you going to do about it? So he says, nothing. We have cordoned off the entire district. We have started door-to-door survey of every single household in the urban area and the rural area. So I said, you'll be able to go and do a household survey of 2 million people? He said, yes, we've already begun doing it. And if you look up Bilaspur and whatever was done during the March 2020, you will be absolutely taken aback that this was possible. Handholding was being done by the Central Health Ministry, no doubt, but the actual work was done there by the district magistrate. And I said, can you give me some idea of what are the numbers, where are they going, who are these people, how many are quarantined, how many are isolated? Because I didn't believe him, frankly. And I was going to do a piece on this and I wanted to be sure. And he sent me by WhatsApp all the documentation, which I still have, by the way. So I'm trying to say this structure, I'm digress to the story only to tell you that this structure is absolutely irreplaceable. The day you try and tinker with that structure, whatever you have by way of healthcare will really, really not work once you go below the tier 1 cities, because below that, there is no structure except this structure, and no great private hospitals and all work over there. Once again, the poor have to depend on the public health sector. Now, coming back, I've given you an idea of what is public health, what is preventive health, what is this whole structure from primary health right up to tertiary health in the medical sector. And having given you this overview and also covered the fact that there are communicable diseases which are coming down, they are down to about 33%. When I was in the health ministry, they were about 65% of the disease burden of the country. They've come down to 33. Whereas the non-communicable diseases have just exploded. They reached 56% of the disease burden in I would say it was 2016. You can look it up. It is the State of the Nation's Health, Health of the Nation or State of the Nation's Health. It's a publication of ICMR, of the Public Health Foundation of India, of Niti Aayog has also been associated, and ICME, which is an institute in USA. You just look it up. Soumya Swaminathan was then the Director General of ICMR. So she has then, and there's a forward by the Vice President and all kinds of things. So it was associated with the government, not something quite outside, but done very professionally. It gives you an idea of what kind of communicable disease explosion has already taken place in 2016. Now the NFHS, the National Family Health Survey, is something that is undertaken every 5 years. And the last one was in the year 2015-16. And we now have the results of NFHS 5 for the whole country. We did get it a year ago for the 22 states, and now the latest states have been added. So you have the picture for the whole country. When you look at that, what comes out of that, and I have a large number of slides, which I'm not going to bother you with, because I do feel that slides tend to take away from your focus on what the argument that the speaker is trying to make. But if you want, I can share some of those with you later on, and or send them on to Shri or your colleague, whoever you want. You can have them because they are really, I would say, very, very telling material. But it suffice to say just now that NFHS 5 compared to NFHS 4 shows a huge burgeoning, meaning it was bad enough with 56%. If that same percentage is to be done, NFHS has not done a percentage of the country, but it would be even higher, which is why it is important that governments spend a lot of attention on preventive health of these non-communicable diseases, particularly in India, because somehow Indians have a propensity, literature says so, I'm not saying so, to get diabetes. And that is because of our eating habits. You know, this whole culture of fried stuff, of having samosas and pakoras and rasmalai and all that, it is something which your taste buds have become acclimatized to right from childhood. Street food is also mostly deep fried. So this sort of saturated fats are getting into you, and cholesterol is going up, and before you know it, the obesity has started, when it becomes very difficult with obesity to be able to treat diabetes, or to even to control diabetes and hypertension. And those are very, very problematic diseases. So to round what up, the round up what I'm trying to say to you, I know I should finish now. It is about 3:45, and you had asked me to speak for 45 minutes, even if 5 minutes went in all that business of audio and all that. To wind up, I feel that before, in the budget, they have placed a lot of reliance on two flagship ideas. One is the ecosystem for health, whereby they would be having digitalization of the entire spectrum of hospitals and networking, plus down to the, you might say, reference point of the individual and his records. Through that digitalization, it is hoped that this kind of specter of the patient having to just go from one doctor to the other, then go and get diagnostics done, then get pathological, and then go and go to another doctor. And this kind of, you spend months just doing that kind of thing, which is very, very taxing for a person who has no contacts, who has no links, who doesn't have any introduction to anyone. He doesn't even know the difference between what is nephrology and cardiology and all. They just haven't even heard of these words. For these people, digitalization is considered to be one way of overcoming and leapfrogging across this huge chasm which exists. My take on that only is it's excellent, but are you talking about the public sector or the private sector or both? That's not clear in the budget. It's also not clear that whether once you bring the private sector, you're talking about the organized private sector or the unorganized private sector. Because as I told you, the unorganized one is very, very, it's run like a business. It's run from the homes of people, literally. Whether you'll be able to bring those people on track, I don't know. Because ultimately, it is, the question will be, are you helping the largest number that need the help? It's not a question of helping a proportion or a percentage. It's a question of helping the largest number of people who need your help. And they, as I told you, are the ones who go to these small fellows first, small hospitals first. Will those people really be capable of coming on track? And then issues like consent will come up, issues like privacy will come up, issues like compliance, who will enforce it? And who will also be able to see that the education to understand the digital network there exists. Of course, a brilliant job was done with CoWIN. The CoWIN app was so simple, it was so slick, and it worked. But CoWIN was a one-time thing of vaccination. Everybody wanted the vaccination. You had to go to a place, maybe you sat for half an hour, maybe you sat for 1 hour. You got your jab and you came out. That was a single point kind of a program. This would be, I guess, across the board for everything that people need. The other flagship that they have program they have announced is about the mental health digitalization program, which is well taken because the number of mental health problems have gone up exponentially. In India, it is stigmatized. Nobody talks about anybody with mental health, but depression and bipolar disease and this over anxiety and being able to get into these kind of compulsive disorders is pretty wide. And as a result of COVID, it has become much more pronounced. This has affected people's brains and people are not talking about it, but a number of families do have this problem of having been locked up. Locked up means you just don't know the future. You have to deal with problems which you never had to deal with. Maybe you lost your parent, maybe you lost a spouse, maybe all your finances are in a mess. You don't have any papers. All this can be very troubling. And people have fallen into this. To help them, the government has decided to set up this kind of a mental authority, which would be able to digitally, right, with the combination of NIMHANS Bangalore, which is the National Institute of Mental Health and Neurosciences, and the IIT Bangalore, together to be able to, on a hub and spoke model, work with 23 centers across the country to give digital consultation, help, and support to people who need it. My question to that is only one. Are you talking of people who've had a post-COVID phenomena, or are you talking about a very much larger network of people who have mental health problems, which are pretty serious and they require face-to-face consultation and even hospitalization or institutionalization? That is a very big sector by itself, and we never talk about it. But I don't know whether this program is only meant for these kinds of diseases or those, because mental health has not been defined to the best of my knowledge. If it has, then I beg your pardon, I couldn't find it. So these are the two flagship programs. They have topped up what they are giving to the National Health Mission, which is your huge program, which is going on from 2005, which was aimed at bringing down maternal mortality, infant mortality, to push up institutional delivery as against home delivery, to be able to do antenatal checkups, those things. That has been a tremendous program, because from 2005 to now, the maternal mortality rate has come down, even in the erstwhile Bimaru states. They're now called euphemistically EAG states, that is your old Bimaru states, you know them all. All these indices have come down, and really India can really be very proud that we managed to do without coercion. Were able to get women to get a modicum of healthcare during delivery. In fact, starting with tracking the pregnancy. I mean, it started as early as that. That has been a runaway success from 2005 to now, and every government has supported it. And this government in the budget has also given it a leg up. They've also given a huge leg up to the AIMS type hospitals, the government medical colleges, upgradation, conversion to medical colleges. All that has been given a substantial amount of money. Somehow or the other, it was not so spoken by the finance minister, but I have the PDF of the announcements in the health sector. And in fact, all sectors, came in PIB. So if you look it up, you will also get it on the net. So you get a bird's eye view of who got what. At least in the health sector, it is pretty clear what they got. So I would say, to finish my talk today, I have tried to give you an overview. I've tried to give you an idea of where I think the future problems will lie, and why the investment, which is today still pegged around, it was 1.8, and that was because a huge influx of money was given in, impetus was given last year because of COVID. So that pushed up the contribution from the central government, but it is still nowhere near what other countries in the world are doing. Absolutely nowhere near it. And without investment, and without having a backbone of some insurance, because in our country, there is the insurance of Ayushman Bharat, which is for the hospitalization, not for OPD. And OPD is where the poor go from pillar to post looking for prescriptions, meeting doctors. That is not paid for by Ayushman, only hospitalization. And sometimes the OPD treatment goes on for months and months, and people pay through their nose because doctors just take them for a ride. Other people take them for a ride. That has not been given any top up, except for the Ayushman part, which is the hospital part. And then you have the other part, which is the Ayushman was one. And yes, in the organized sector, we have our, in government, you get the CGHS, the ESIC, state governments have their own health security systems. All that put together, all that with Ayushman, it still leaves 26 crore people without any health insurance. Now, because of COVID, they've all rushed to try and get insurance policies. But one would have expected that the budget would have tried to give some hand holding to the unorganized middle class, particularly the small, the petty trader, or the small businessman. These are not people who are earning that much money. Yes, they might be not paying income tax. They may be earning lakhs of rupees. That's the other side of the story. I'm not going into that. But taking them for whatever they look and whatever work they're doing, I do feel that a country which has to look after its people has to give some sort of incentivization that you take this much insurance and we will top it up with this much insurance. That was expected. It may still come, because some friends of mine were working on this missing middle kind of sector of the population for insurance. And I even did a podcast where the joint secretary in charge of insurance came. You can listen to that podcast. You've just to put in Shailaja Chandra podcast, and you will find 8 of my podcasts. The one on health insurance is the one that you should listen to, in which the joint secretary in charge of insurance in the finance ministry tells us about what they're thinking of doing, but he was not very, very clear about when. Certainly didn't come in the budget. So one can hope that it will come in due course, but it is a major area of concern, not having health insurance for so many crore people. So with that, I have tried to, in a short time, cover a very large canvas, and I would be very happy to hear from you what kind of questions you have, what your concerns are. Thank you. And thank you for inviting me.
Thank you so much, ma'am. It was indeed an insightful lecture. With the COVID-19 pandemic, the issue of healthcare and the condition of public healthcare in India have become even more pressing. With your permission, we'll now move on to some questions from the audience. So, like you mentioned in your address, the previous budget, that is last year's budget, was very heavy on healthcare given that we were in the midst of a pandemic. Huge allocations were made in this respect. So in your view, are we self-sufficient now? Did the investments pan out as planned? Or do we still have a long way to go in this regard?
You know, whatever infusion of funds was given, nobody has ever said where have those funds gone, how much has been used, how much has not been used. That is really a job which the state governments have to take up. Each state has to say, how much did you give us? And why have we been given only a proportion of what we should be getting as a state? Because usually there is a formula through which the allocations are made. This allocation was primarily, I think, to boost up vaccination, and that has happened. There was a lot of problem in between when a view was taken that we won't even buy the vaccination. There was delay in that, there's no doubt whatsoever. Then when the vaccines were ordered, then the question of whether it will be done by central government did it for the elderly, and they did it for people, for the frontline workers and the people with comorbidities, but they didn't do it for the whole population. They left it to the states. And initially the states also, instead of saying no from the day one, they blundered into global tenders and things like that, and they realized it's just not possible. No global tender is going to even look at paper coming from a single state government. They want a national guarantee that this has the backing of the government of India and is going to be on a large scale, not just state by state. So when that floundered, then they went back to saying they will do everything. So if the money has gone into paying for vaccines and for seeing that the vaccines are administered, then it was, I think, 35,000 crores, which they said had been given. If that money has been allocated and used, great. But I have not come across any examination of this. I wouldn't be able to give you a yes or no answer, or even to be able to hazard a guess. But certainly the vaccines have been bought and they are being administered. There's no doubt about that.
So I think with that, we can end the session. Thank you so much, ma'am. It was an absolute honor to host you. I believe I speak for everyone when I say that we have a much better and deeper understanding of the union budget with a healthcare perspective and have a lot to take away from this riveting session. On the behalf of the Economic Society, I extend to you my heartfelt gratitude for taking out the time from your busy schedule to be with us today. Thank you so much, ma'am.